I sound?
Great. Perfect. All righty. So here in about
those videos were awesome. Jeez.
Yeah, we still have about 3 minutes left on it. And I think what we're going to do, we're going to have some time at the end of the day, by popular request by several people, it's an incredible video by Brandon Clement with the drone.
Oh my God, that was so awesome. Absolutely, probably one of the best videos.
Yeah.
It starts off slow and you're like, yeah, but man, when he wraps around that thing.
Yeah.
I want to know what drone he uses that doesn't get knocked about by RFD, because he was like all in there, man. It was incredible.
It's a DJI Mavic Pro.
Oh,
that's
God.
the model of the drone he's got, and he's made some custom adjustments to it.
I imagine so.
He's a really skilled pilot with that thing, though. It's amazing.
No, totally. Yeah.
In that tornado, I tried to get to that tornado. I was on I-35, and he was just to the east near Sulphur, which is 7 miles.
Yeah.
And I couldn't catch up to it. That tornado was flying, and the fact
when was that?
April. I don't remember the date. It was in April last year.
Okay.
Yeah.
That was that had a pretty impressive velocity to it. As I recall, the upper level winds were kicking at around 75 knots.
Yeah, that was the same day that we had multiple tornadoes that day in Oklahoma. I'm trying to think all of that, but yeah. It was really the only event we had in Oklahoma all year. So.
Yeah, it was 2020. You're gonna laugh. I think it's in my 4th or 5th slide. You'll like the correlation I show you.
Yeah.
So.
Okay, we're gonna do a little intro video, and then it's all yours.
Fantastic. I'll be ready to go.
And then we'll let you screen share.
Excellent.
All right, coming back out of lunch, our video that James worked on. We loved his intro. Go ahead.
I'll play it as soon as I find it. Okay. Sorry, and
just let it play.
Yeah, I need to do screen
share.
share.
Technology.
So awesome. That's some damn fine. That's some damn fine work right there. I'm just telling you.
Thank you.
Okay, welcome back, everybody. We'll get out of that screen share. Welcome back, everybody. We all know Dr. Persoff. He has been around for several years, especially some great, wonderful talks. And by popular request from, I don't know, over 200 people, I think, requested him to speak. So unfortunately not in person, but he has been doing great things in Denver with COVID-19. And he, of course, is an amazing chaser. That photo of his was amazing. I always followed him through the years and looked up to him. So, Dr. Persoff, it's all yours.
Well, I thank you so much. It's great to be here. It really is. I am going to just share my screen because my ugly mug. Somebody has properly noted that I'm beardless, and the reason behind that is this damn plague, because my face mask has to be skin tight, and unfortunately my beautiful beard is gone, and now I feel naked. That's right, I'm giving this presentation naked, even though I'm supposed to envision you guys as naked, but there it is. Anyway, so I get it. You're here after we just watched some of the most amazing tornado videos I've ever seen. We're here talking about COVID, which is exactly what you want, but I promise it's got a storm chasing bent to it. And we're going to talk about chasing during your plaguecation coming up this spring. So first of all, I get it. it's COVID. Why are we talking about COVID at a chasing summit? Well, we're going to go through that. I mean, really, why are we doing that? And I promise I will stick to what you need to know about COVID because it is important, and specifically how it relates to chasing. All right, so let's start off with an interesting correlation that I happened to notice as I was preparing this talk. First of all, let's take a look at tornado nadir years. Now, these data that I'm showing you right now are the number of tornadoes that have been cataloged in each calendar year. And as you can see, 2020, of course, is in a nadir. But interestingly, let's take a look at this. This occurred in 2003, the avian influenza during that nadir, and H1N1, MERS, Ebola, MERS, and SARS-CoV-2. So clearly there's a connection. Every single year we have a nadir in tornadoes. We unfortunately seem to have some form of epidemic. Coincidence? I think not. Well, actually, let's talk about that because this has been the year of scientific fallacy, much as I'd like to believe that there is some sort of correlation. And ergo, thinking about this going back, if we could only raise the tornado count naturally, we would see a dissipation of the viruses. And I'm hoping to publish on that someday. But in reality, these are scientific fallacies. And it is expressly this kind of specious reasoning that we've seen during COVID that's been very, very harmful. And so today I'm going to set the record straight on a number of things and how they relate to chasing, and hopefully convince you that this is, you need to pay a little bit of attention to it. The news cycles have been horrible about this, but you want to know the truth, I'll give you the truth, I promise. Now, in order to do that, we have to agree together that storm chasing is a rigorous evidence-based principle and uses scientific applications, meaning that all of us who chase storms use science on a regular basis. And discussions of COVID really should stick to the science. And so if you are blabbering about, and everyone's heard me talk about this before, I don't really subscribe to the idea that storm chasing saves lives. I do believe that forecasters are able to pinpoint better tornado warnings because of the efforts that we have in the field, but it's hard for me to really envision how we truly save lives. But a lot of people claim that they do. And if your mission is to save lives, or that you're going to perform science, which we're going to hear about rocket science right after this, it's going to be great with Reed, then adherence to science should be your underlying motivation while you're storm chasing. And so given that, I'm going to give you the science, and we're going to rely on the science as we discuss about this. All right, and part of what this year has felt like to me is this video from...
This man right here is my great-grandfather. Wow. He was the first cat herder in our family.
Herding cats. Don't let anybody tell you it's easy.
Anybody can herd cattle. Holding together 10,000 half-wild short hairs, well, that's another thing altogether.
Being a cat herder is probably about the toughest thing I think I've ever done.
I got this one this morning, right here, and if you look at his face, it's just ripped to shreds, You
see the movies, you hear the stories, I'm living a dream. Not everyone can do what we do.
I wouldn't do nothing else.
It ain't an easy job, but when you bring a herd into town and you ain't lost a one of them, ain't a feeling like it in the world.
EDS, managing the
absolutely
this man.
But that's what my year has felt like, is it's been a lot of herding cats, I have to tell you. So let's talk about coronaviruses first. As you can see in my background, I decided to incorporate it in radar signature. I believe the radar signature was from May something 2019 in eastern Oklahoma. I can't tell you much more than that. Anyway, this is coronavirus, your enemy, my enemy, and all coronaviruses have very similar structures. And it's an RNA type virus, which doesn't mean a lot unless you really want to know the details. I won't go into, but basically the thing that makes coronaviruses contagious and how they infect our cells are through these spike proteins, which are labeled S in the diagram. It is the spike protein that the current mRNA vaccines target, And it is the area where we are most worried about different types of mutations. Interestingly, for a lot of you who may have gotten antibody testing to find out whether or not you had COVID in the past, most antibody tests are actually not designated to find whether you have the spike protein. They're actually for the membrane protein, a nucleocapsid protein. And why this is important is those of you who've gotten mRNA vaccines, and there's probably only a few of us here who have, your antibody tests will come back negative because the antibodies are targeting the S protein, the spike protein, and not the actual nucleocapsid. Now, COVID has been doing a lot of weird things, and we're going to talk a little bit about what the trends have been with COVID as we go through a lot of different scientific stuff. But this is actually taken from this morning, and I want to show the frequency of new confirmed COVID cases by day. And this is called a normalization chart where it normalizes it by population. And that's important when you're going to include Texas in any chart, because Texas has, by virtue, a very large population. So it normalizes it out. And one of the things that's very interesting to actually see, and if I continue this chart back further, it would be even more interesting, is you'll notice that back here, this is around November, the end of November. At that point in time, Nebraska and Colorado were experiencing a very significant spike. In fact, that was our worst spike for COVID. And then it sort of has gone down and decreased. And then later on, we see that the spikes are occurring here in Texas, Oklahoma, and Kansas. And while there's these little blips in Colorado and Nebraska, they're very, very small. This is actually a continuation of the very large amount of COVID that was seen in November. There is a delay that occurs between big cities and the rural areas of the country. And this has actually very important implications for storm chasing, which is to say that when we're out chasing during May, a lot of models right now are looking very encouraging, despite all the different variants that you've heard about, that we're going to continue in a downward decline, which makes a lot of sense. There are approximately 7 coronaviruses which infect humans, and they follow a seasonal variation starting usually in September and usually going away come February. COVID, being just one of these coronaviruses, is likely to follow a very similar trend and develop a seasonality to it, much like we have respiratory virus season when we get flu, runny nose, colds, which starts in the fall and goes until the spring. COVID should achieve that same seasonality, being a coronavirus. However, that didn't happen last year because it was a novel virus. It had never been around before, and so we had a huge explosion. By far, the second surge was worse, and if we get a third surge, it will likely be worse than the previous 2. So we're really not out of the woods yet. The key is that there is going to be a lag behind, and rural areas will experience these spikes later. And when you normalize them to population, especially in the Midwest, you're talking about very big sections of the population. As you look at Oklahoma, for example, very big segments of the population in the rural areas being affected by coronavirus. And so you really need to be mindful of the fact that there is about the 6-week delay between much more metropolitan cities and much more rural areas. Now, when we talk about SARS-CoV-2, which is the correct name, I will tell you that though the virus started in Wuhan, China, it is not the Chinese virus. And we can debate at length that we don't know what actually led to the initial infection, and that's fine. I think there's a lot of data to support that it's a natural mutation, but regardless, I'm not going to dive into that controversy. The term SARS-CoV-2 has been chosen because that actually reflects very much what the virus looks like compared to SARS-1, which we never really dealt with in the United States because at that time, good public health measures were taken. When you look at infection from SARS, it goes through a very, this is a kind of a noodly chart with a lot of different lines, and I'm going to just break it down to the most important parts. If you talk about infection, usually most people will spend that first week that they're infected. And the blue line is basically this uptick of what we would call infected virus in the upper respiratory tract. That first week is spent asymptomatic, and it can last almost up to 2 weeks in some people, where they have absolutely no symptoms, but are extraordinarily contagious. And there's no clue that you may have that. That period is the part that really makes SARS so darn tenacious and has been one of the reasons that it's gotten out of control in this country to begin with. Now, just so you know, in terms of antibody response, we actually don't start making good antibodies, which IgM is your first antibody that you make, which targets the virus, for almost 10 days after we start having symptoms. So it takes a while for us to clear this virus out of our respiratory tract. As we'll talk about later, 60% of people are not going to have any symptoms through this whole process, which means that it's a highly transmissible virus, and that's what makes it so deadly. So just keep that in mind as we go forward. Now, here's how it spreads. We know now with certainty that there are definite ways that it spreads. Droplet and aerosol is the most common, and I'm going to show you a video in a moment of just how easy droplets spread from human to human and aerosol transmission. And basically everything from speaking, and the video I'll show you is counting numbers, generates droplets and aerosols from the upper respiratory tract where SARS-CoV-2 likes to live. We know that coughing definitely does. Talking loudly, this is a problem that I suffer from, and also my oldest son, is we tend to talk very loud. But talking loudly, and in addition to that, shouting and singing, which to me, my singing sounds like I'm shouting, and talking loudly, it's not really in pitch. You don't want to hear it, trust me. Those all definitely spread the virus. In addition, belly laughing, which I'm hoping some of you are doing. The problem with this kind of format is I feel like I'm talking to my kitchen, and my kitchen is reacting probably actually the way I think many of you are at home. Exertion can definitely do that. And then everyone loves to hear about stool and fecal oral spread, but the reality is SARS-CoV-2 infects the gut, and high quantities of it are found in the stool. And we'll talk about that in relation to using public restrooms and why all of those got shut down, which, by the way, many of them will remain shut down. The rest stops are still shut down in most states. So if you're traveling, you can't just pull into a rest stop. You're going to have to go to one of the gas stations. The stool, bear with me, splashing in the toilet and getting on the toilet seat, and then somebody coming in, sitting on the toilet seat and not washing their hands, that can actually lead to infection with SARS-CoV. This is the way it struggles to spread. So I want to talk about contact transfer momentarily. I can remember back in March and April watching people bleach wipe down their bananas, just in case there's lots of SARS-CoV there. The good news is that you're very unlikely to spread SARS in any way, shape, or form from contact transfer. In other words, when the pizza is delivered or when you're shopping, the ability to actually get SARS to remain viable on objects is very, very difficult. There are studies that definitely show that SARS can live on objects for very long periods of time, depending on the object, up to 8 hours, and in some cases they've recorded it for days. But that's not viable virus. So the virus has to be viable, in other words, living, in order to infect us. And it is very, very hard for the virus to do that once it hits a surface. It spreads out, it breaks down. You do not need to worry about that from contact transfer, which includes casual contact. You also can't get it from pets or visiting the zoo. So forecasting, I found, definitely does not spread the coronavirus so long as you're doing simple forecasting. Complex forecasts like winter forecasts may spread it. Zoom calls don't spread it, which allows me to both talk loud, belly laugh, and shout and sing to my heart's content. Now, I want to concentrate on this thing called viral load, because viral load is actually a really important concept in the disease model of SARS-CoV-2. It's the number of viable particles, and note the word viable, meaning particles that can actually infect you, times the amount of time that you're exposed to them, and it's measured in seconds. We often talk about minutes, but in fact, if somebody coughs on you, seconds are all it takes for you to get a high viral load of SARS-CoV-2 and get infected. It just takes one cough or one sneeze. But even talking to somebody and you're not a few feet away from each other, and you talk for over a minute, the chances are that you could also capture enough viral particles to get sick. It is extremely transmissible. Just to underscore this, this is what happens when you exhale, cough, or sneeze. all these little red dots by the worst drawn human being I've ever seen. And I can't draw either, but I think that if I did, this would be probably about as good as I could get. Just speaking results in particles that will fall approximately 7 feet away. That's just speaking. Coughing takes it even further, but sneezes take it out to 6 meters. Now, for those of you who can't quite do metrics in your head, that's up to 20 feet. A sneeze can eject particles, large spray droplets, 20 feet. So it's got some momentum behind it. Now, how does this relate to storm chasing and what's safe and what's not safe in storm chasing? Well, we'll talk about this in terms of risk, because I know you guys understand this. Let's talk first about marginal risk. There is a very low risk of you getting SARS-CoV from gas pumps or motel rooms. This contact transfer issue is a real deal. If you go to a motel room, even if the person who made up your bed coughs on their hands and has a little mucus kind of out of their corner of their nose that they kind of, just sort of wipe on their hands, and then they make your bed using the God knows what else has been covered on your bedspread. Even if all of that occurs, the chances of you getting COVID is extremely low, because every single minute SARS is out of the body, it becomes less and less effective at transmitting disease. If we, in some of our protocols, even though in the hospital we take very rigid protocols where we wipe everything down and then we wait 15, 20 minutes for a room to be considered sterile, the time between when the bed is made and the time that you would be intimate in the bed, whatever that looks like, and we don't need to know, I can imagine, because that goes back to the bedspread thing. But anyway, that period of time is usually enough to result in sterilization of the virus. So you can go to gas pumps and you can go to motel rooms, and the chances of you getting COVID-2 from this is extremely low. Now, low risk activities are these sorts of things, like a brief contact during windy conditions outdoors. So you can be out of your car while we're out videotaping a tornado. Hopefully, I certainly saw some ones this lunch that oh man, those were beautiful. If we're out there doing that, the chances of us spreading the virus are extremely low, because the wind is going to actually disperse the particles very effectively. And so being outside and being excited during windy conditions, this past year when I was chasing, I ran into some other chasers at gas pumps in Western Nebraska after the photo that you guys saw that I took in Western Nebraska. And we were a good few feet apart. It was windy. There's a very low risk. We're in good shape. Viral loads are going to be extremely low. Moderate risk activities are any close contact outdoors without masks for 5 minutes. So taking the same storm chasing scenario, if we're out there getting our tripods out, even though the air is being dispersed, it's the time that matters. So a period of time of greater than 5 minutes where we're all out there, and God, I just keep thinking back to Dodge City in 2016. What an amazing set of tornadoes that was. Most of us were out of our cars for an extended period of time with the slow moving system. And in those circumstances, even with wind, you are taking a moderate risk for developing COVID. High risk. Common areas in motels are high risk. This includes check-in, especially check-in. And I believe most hotels that I've been in have closed their common areas down. But that doesn't stop people from pooling in those particular areas, particularly as we know in the mornings where people are using Wi-Fi to go ahead and look for data. These common areas are extremely dangerous areas. They're high risk. You're talking about a number of viral particles in those areas over time. And that's including mask wearing, but with mask wearing, it becomes much less risky, but still the goal is not to congregate, and that is very high risk. Now, what we all fear, oh wait, no, not yet. Darn, I hate when I do that in a presentation and I advance beyond where I went. But casual contact inside a vehicle is a high risk event. So if you have your radar pulled up and you're gonna show somebody something on the radar and they poke their head in the car, even though that's just a few seconds, if they're unmasked, the viral load is extremely high. So if they're infected, and like I told you at the very beginning of this talk, you can go 7 to 10 days with no symptoms. In fact, 60% won't even know they had the virus, and they are spreading that virus like wildfire. So casual contact inside a vehicle can do this. Gas station lobbies are the same issue, as are the restrooms there. Although you should be practicing some form of socially distancing in the bathrooms. I don't want to call out names. Anyway, these are the PDS risk. Okay, so a particularly dangerous situation. This is what I was trying to get to earlier. Communal travel is probably a no-no, even if you're in a multi-person fire-emitting drone. Vans, buses, I know that storm chasing is a social sport, and I want to strongly discourage you from doing this. Communal travel, again, there's also a lot of people who have talked about getting tested before they go out on like, for example, for travel. This happened a lot during Thanksgiving and Christmas, where a lot of people got tested before they went and traveled and felt confident that they were negative. To go back to that previous slide, you may test negative because some of the tests are not designed to actually pick up COVID particularly well. So the saliva tests are not as accurate. In fact, there's a 5 to 10% chance that it will not pick up SARS-CoV-2 even if you are infected. Whereas the brain biopsy, the one where we go in through the nose and try and poke a hole into the brain, and usually people are like hemiplegic for a few seconds, that test is extremely accurate and won't miss virtually any of the virus. But it also requires somebody who really knows what they're doing. For those of you who have been tested by the brain biopsy technique, you will know it is done well. And if it's not done well, it's not done, pretty much, okay? It's done well if during the test you feel an overwhelming urge to cough or sneeze, and you cough or sneeze, and at the same time, they're in your each nostril for 10 seconds. That 10 seconds is awfully long, believe me. That is the gold standard test. These other tests are not necessarily as accurate. So the idea that you're taking a test to prove that you don't have COVID probably doesn't hold a lot of water. It will certainly be helpful if it's positive, although with the saliva test, there is a false positive rate, whereas other test modes, there's not. So you could be told that you're positive for SARS-CoV-2 and you don't actually have the disease. So just be aware of that. Also, antibody testing for immunity is not a thing. People who have become naturally infected by SARS do not necessarily have protective antibodies for an extended duration. We know that the immune system is very complex, but it's hard to believe. I was looking back at my email. It is exactly a year and a week ago that we began talking about this as preparation in my disaster committee over at the University of Colorado Hospital. So it hasn't been that long. In 1 year, we have had an unbelievable explosion of science that is just fantastic. But we really still don't know how long immunity is and how likely it is that you're going to stay immune if you've had natural infection. So I have to tell you, communal travel is probably a no-no going into this spring. Hopefully this is the last spring I have to say that. Eating in a diner or a restaurant should remain a no-no. There's just no way for me to reconcile the process of taking off a mask to eat. I mean, I suppose if you're just eating and not laughing or talking or anything else, you might be able to get away with it. But I continue to tell people not to eat in a diner or a restaurant. Get the food to go. That's really important. I also, unfortunately, and this has really affected me, is I don't recommend working out in a gym. Not that that happens a lot when I'm storm chasing, but I tell you that because the exertion in gyms is actually considered the most effective way to transfer COVID. All right, so I'm going to go ahead and start this video in the background while we talk about face masks. And I've heard this a lot. People are like, viruses are so small. How can masks possibly stop the virus? The key here isn't that we're trying to stop a single viral particle. A single viral particle will not get you sick, but a million or a billion of them can. Turns out we need about 150,000 to 1 million viral particles to transmit disease. This woman here is, in all these videos, is just saying the numbers. Number 6 is particularly bad, as you can see. Notice how her particles come out, and then as she breathes in to say the next one, they go back in her mouth. Over here we have, in the upper right, just a single layer, just like a gator. Still have some particles, but not bad. As soon as we get 2 layers, And as soon as we get a surgical mask, you don't see any of those particle or any of those droplets. And that's really the key here. Those droplets are what transmit disease. So here's coughing, really gross, really disgusting. With a single layer mask, you still get a lot of particles. You still with a double layer mask, but notice that they are different. These particles do not have a great deal of momentum. They stay closer to the person who's coughing, and that's really helpful. How about sneezing? Well, let's watch this. It's so cool. It's almost as cool as Brandon Clement's video. What we need is drone footage of that. Oh, isn't that beautiful? Look at that. Really nice and meaty. That's a beautiful sneeze. So anyway, you can clearly see the difference. For those of you who wonder, should I take off my mask and sneeze into the crux of my arm when I'm wearing a mask? The answer is no. Wear the mask. It's okay to sneeze in your mask. It's far better than sneezing out loud. All right, so viruses are small, but that's not really what we're talking about. That's a false equivalency. Single viral particles don't cause illness. Viruses must be in a moist environment for successful transfer. And moist is still considered the most disgusting word in the English language. I never knew how many times I would use that in this past year. Just to give you an idea, this is a surgical mask versus an N95 mask. Here's the size of a human hair. And if you're coughing up human hair, you have some issues, and I recommend you see a doctor. The coronavirus is about 0.1 micrometers in diameter. And what happens is as it travels through, and this is true for all masks, not just surgical or N95, these viruses get slowed down, and it's the speed that's a key issue here. By slowing a virus down, it is subject to gravity like anything else. And if it's not traveling very far, very fast, it's going to drop off close to that person. But remember, I showed you that slide earlier that the sneeze can travel up to 20 feet, and even just talking can travel up to 10 feet. The recommendation for 6 feet of separation for social distancing is actually not evidence-based at all. The goal is not to be around anyone. That is really the goal. And I know that's hard to take, and we're sick of it, and I hear you, but we'll talk about why that's important now. All right, let me deal with some misconceptions. If you don't believe me, I have tons of studies to show you that have been conducted scientifically. And like I said at the beginning of this, we're going to be scientists. Storm chasers are scientists. So I expect people to maintain their scientific level of rigor. Masks do not lower oxygen levels. This has been tested a bazillion different ways. And thank God, because if I were running around getting hypoxic all day at work, I wouldn't be a very effective physician. Not that I'm necessarily am, but it also doesn't raise carbon dioxide levels. The gases pass freely through masks, no matter how significant the mask is. The idea that masks cause infection about the face and increased risk of illness is a horrible, horrible fallacy. It does not. It can cause acne around the face. And if you don't wash a cloth mask regularly or change your surgical type masks, you can get infections around the face from just constant, remoistening. There it is again, damn it. Moistening of the face. A warm, moist environment is one that can lead to that sort of acne and sometimes skin infections. But the very simple truth is, just like any of your clothes, if you were to wear your underwear for 7 days in a row, and I'm not saying that I have, but I have. I'm sorry that I have. I did it again. Anyway, you will eventually have these same issues there too. Masks aren't natural, and my respiratory tract was designed to protect me. I love this fallacy because, yes, that's certainly true, but the law of natural selection suggests that we aren't perfect and we need help sometimes. And the one that really tears me apart is mask use as government conditioning and attacking my freedoms. Look, here's the deal. Mask use decreases the risk of you infecting others and also of you getting infection, and I'll show that slide in a moment. It's a common question of decency, and we'll talk about that. So medical reasons that people can't wear a mask, there are exactly three reasons. One, you have autism with a sensory integration disorder, and I don't mean that comically, I'm being very serious. Individuals with autism have sensory integration issues, and wearing a mask can sometimes be very difficult. If you're a baby or a toddler, which I've noticed a lot of the population is these days, or if you have uncontrolled anxiety or panic disorders or PTSD, those are legitimate reasons not to wear a mask. Otherwise, there is not a single medical condition that precludes the use of a mask. The number one reason that masks don't work and that people can't wear them for a medical reason is the medical reason is they're being stupid and selfish. That's the medical reason. That's the truth. There's no arguing with me about this. I have all the data I have to back that up. So don't be a dick is the bottom line. All right. So to talk about it, here are the 4 personality types that we generally see at the store. Somebody who believes in science wears a mask. Somebody who denies it does not and feels entitled, incidentally. Somebody who doesn't understand science doesn't put it over their nose. Now, I understand masks are uncomfortable, okay? I hate wearing a mask and won't wear one whenever I have the opportunity to take one off. I am with you 100%. They suck. They make my nose cut off. I don't feel as comfortable in them. I get it. But when you don't wear the mask over your nose, you've basically done nothing. You've done absolutely nothing. Most people are nose breathers, and therefore most of the breathing and things that we do eject virus out of the nose. So you're going to spread it. And you're not going to be protected either because we do most of our breathing through our nose. Very few people are true mouth breathers. And then, of course, the last one, which is the person who's got the chin mask, which is, just magical belief systems. You want the data? Here's the data. This is basically an aggregate of all of the studies that have been done to look at what mask use does in terms of reducing the risk of infection. Now, those of you who don't do a lot of scientific journals, I'm going to really quickly just teach you a little bit about this. This big line that you see right over here that is connected to the number 1, this basically determines whether or not something is or is not helpful. Everything to the right of that line suggests that the particular intervention is not helpful. Everything to the left suggests that it is helpful. Anything that has what's called a confidence interval, which is a horizontal line, okay, that crosses over 1 suggests that it is helpful, but it's not scientifically, statistically accurate. It doesn't prove it beyond a reasonable doubt, but the trend is there. When we take the aggregate, if you come down here, this is what we know about mask use and reduction of spreading infectious viruses from SARS. All of these are coronaviruses here. What we see unequivocally is that not only does it favor mask use, but it doesn't even come close to crossing 1, which means it's scientifically robust. This is 100%, and the mask use varied depending on the study, but they're very significant numbers here. All right. Why do masks work? Well, they decrease spread from one person to another. And here is really key. They decrease viral loads. So simply by wearing a mask, the amount of particles that come out of you are lower, and vice versa. If you're not wearing a mask and somebody is, or if you're wearing a mask and somebody isn't, the amount of viral load you get directly correlates to disease severity. That is one of the best reasons I can give you for wearing a mask. It turns out that viral load is the single most biggest predictor that we know of people having severe illness. Now, there's a lot of people who are like, yeah, the people who die all have comorbidities. I can tell you that I have pronounced multiple people in their 20s who died with no comorbidities. And people will say, well, maybe they had some hidden problem. Most of these people did not. At least 2 of them were athletes and had nothing wrong at autopsy except SARS. So it does kill people. It is more likely to kill you if you are obese, if you have high blood pressure, if you have diabetes, cancer, and if you're older, for sure. But you're not safe just because you're young. And we're seeing a really amazing amount of kids who have long-term complications from COVID. Now, the frequency is extraordinarily small, fractions of a percent. But as a parent, I wouldn't want my kids to have that. But we know that viral load leads to more severe illness. And so if you're wearing a mask, you're less likely to die. Isn't that great? Don't you want that? That's good news. Now, social distancing has to be used with mask use. So if we look at this chart, this is a very good chart that shows that if we just act normally, and we'll talk about the R naught, I think, in the next slide, 1 person will infect 2.5 people. That's called the R naught. And within 30 days, that 1 person will have infected 406 people. If we reduce our contact all the way to 75% less contact, in 30 days, that's 2.5 people who get sick. So social distancing is absolutely vital. The problem that people still have to wrap around in their head is they may have no symptoms, none at all, and are highly infectious. And you don't know who those 406 people are going to be. And so if we talk about saving lives, which we talked about as being a vital thing as a storm chaser, This is how you save lives. You socially distance, you wear masks. If you want to save lives chasing this spring, this is how you do it, in addition to any warnings that you can help generate. So the R naught is an important number to be aware of. It's the number of individuals a single person can affect, and there's very many things that affect it, but the biggest is social distancing, the infectivity of the particles. So we know that SARS-CoV-2 has around a 2.45 R naught, which means that, like I told you, one person will infect roughly 2.5 people if we just have normal behavior. Social distancing and other measures lower the R naught, and this is from this morning, okay? And the data comes from this website. This is the various R naughts of the virus right now, just the highest numbers of the R naughts. Any R naught that's less than 1 means that the virus is contracting in the community, and that's exactly where you want it to be. You want it to be less than 1, and you want it to be well less than 1. Sticking to the themes that of storm chasing, we notice that both Texas and Wyoming are right on the edge, okay? But when we come down here, here's Oklahoma, Mississippi, which is the chasing season going on right now, North Dakota, those are all greater than 1. And that's a big problem. That means it's spreading in those areas, and that you really need to be better about mask use, et cetera. And then poor Bernie, those mittens aren't going to help. That's the wrong type of mitten. Apparently, that is the worst place in the United States to be. So just FYI. So this is by Ian McKay, and it basically says that the way we get over this pandemic, the way we go back to chasing the way we want to chase, the way we get to spend time together, is going to have to be through a multiple process. Every one of the slices of that process they're not perfect. They're never going to be perfect. There is no such thing as 100% perfection. And everyone has both a personal and a societal responsibility in order to get out of this pandemic. Physical distancing, staying home, wearing masks, hand hygiene, avoiding touching your face, which is funny because I actually touch my face less when I'm wearing a mask. Oh, by the way, I wish I had a mask right in front of me. I'm going to grab one in just a second so I can show you. This is how you take down a mask to look at your Apple iPhone. A, and B, don't ever touch the front of your mask. So stand by, stand by. Wow, mask use 101. I didn't even think about that until just now. Sorry about that. Hope you guys didn't go to the bathroom while I was away. All right, most masks that are not cloth masks, or if they are cloth masks, you will grab by the sides, put it on your nose and mouth. You do not ever lower it by doing this. Then anything that's caught in the front of the mask goes right up into your sinuses if you take a deep breath. So that's never how you do it. If you have to open up your iPhone or do something like drink, you want to take it off from one side and leave it looped around the other ear. Never, ever pull it down in front. It's okay if it's up front that you reposition it, okay? That's fine, so that it fits perfectly, but it has to fit over your nose and mouth. You have to be wearing it correctly. There's no way around that. If you have a straw, my recommendation is you keep your mask partially on when you're drinking, but otherwise, if you're gonna take it off completely, make sure you take it off by the sides. Do not touch the front of the mask because that is the infected side of the mask. And don't do what I just did, which is catch it in your glasses while you're sitting here giving a presentation to hundreds of people. Pro tips. We have all these responsibilities. And notice that even though it looks like, yeah, vaccine's going to get it all the way, it's the last slice. We cannot stop just because there's vaccination going on. We have to continue this until we have herd immunity. Now, the reason I want you guys to be very mindful of this is that you don't want this illness. I cannot emphasize that enough. While 60% won't have any problems, a lot of people will have short-term complications, which you guys are aware of now. I want to comment on a couple of them. Loss of smell and taste is not a small deal. Some of the people who lost smell and taste when they got COVID have never regained it. And one of my patients described it perfectly to me. She was talking about how she had a plate of eggs in front of her. She knew they were eggs. And then when she put them in her mouth, she didn't believe they were eggs anymore. They were just this weird consistency of nothingness. You don't want that. And we don't know if it'll ever come back. Most people it does over a period of time, but some people it never does. And so much of my life is made up of enjoying food. You can imagine what that does to people when they don't get it back. Most people will have like a flu-like illness for a few days or up to a week or 2 weeks, but you can lead to multi-organ failure and hospitalizations, stroke, heart attack, and pulmonary embolism. The long-term complications, like I said, are loss of smell and taste. We need to talk about long haul syndrome because so many people are affected by this long haul syndrome. This includes severe fatigue. And when I say disabling fatigue, I mean people can't walk down the stairs without having to take a nap. That's what we're talking about. Or the need to have long-term supplemental oxygen. How would you feel chasing with tanks and tanks of oxygen in your car? Long-term difficulties with breathing, nerve damage, and profound depression and PTSD. It is not benign stuff, this long-haul stuff. It can cause chronic kidney disease. It is probably going to become the #1 need for lung transplant in the nation behind COPD and cystic fibrosis. In the next 5 to 10 years, we're expecting it to be a devastating consequence of how many people are going to need that. And long-term nerve damage, hearing loss, so many things. For every 100 people who get infected, 60% will be asymptomatic. But make no mistake, even if you're asymptomatic, you still get lung damage. The lung damage is usually pretty mild, obviously, because you didn't have any symptoms. When there was the Diamond Princess cruise line, where everyone was infected at the beginning of the pandemic, and they were offshore, the entire crew and passengers from that cruise line underwent CAT scans. Okay, and for anyone who tested positive, 100% of patients who tested positive had changes on those CAT scans of scarring. Scarring was typically small and asymptomatic, much bigger in symptomatic people. We don't know what the long-term complications of asymptomatic SARS-CoV is, and I certainly don't want it. 15% of patients will require hospitalization, 5% will require oxygen long-term, 10% will develop long-haul syndrome. That's 1 out of 10, which can be disabling. And then as people say, 1 to 2% will die, and that's not that many. We'll come back to that in a moment. For every person who dies, 18 people will have permanent heart damage, 10 will have permanent significant lung damage, 3 will have strokes, 2 will have long-term neurologic illness, including advanced dementia from COVID, and 2 will remain hospitalized for greater than 3 months or debilitated so much that they'll never return home. I just don't know how you can look at these numbers and not say, I don't want this, and I don't want that for anybody. Going on, if you think those numbers aren't big, let's try some of these scenarios. If I offered you a sandwich that was made up of 1 to 2% of dog feces, would you eat it? The answer is hopefully no, of course not. And I would also wonder where I'd gotten that recipe. But if I told you that you can take the best picture of a tornado, but for the next 3 to 6 months, you'll be so short of breath, you'll have to wear oxygen 10% of the time, especially during any exertion, including sex, would you take that risk? How about if you bought a new chase vehicle that had a 10% chance of being in the shop all the time? Would you spend the money on that? In most of these circumstances, the answer is no. And I know sarcastically, some people would say, yes, if I got the best picture of a tornado, it would be worth it. I get you. But they all have to do with the same statistics that we talk about, which is science. This is science. And I want you guys to bear that in mind. You promised. If 2020 was a slide, it would look something like this. You know, it's what gets left behind. See the behind on the left. This is the problem with presenting in a kitchen. I have no idea what's hitting and missing. Also, this last spring, toilet paper for $4,000 with a free 1-carat diamond ring. Got to love that. All right, treatment of SARS-CoV-2, and I promise we're going to wrap. I want to say that this has been one of the areas, the Dunning-Kruger effect is what I've seen with treatment. One of the worst things that has happened is the poor application of science when it comes to what works in treatment of SARS-CoV-2. The Dunning-Kruger effect, which is described by both Dunning and Kruger, I know that's strange, suggests that people's confidence on what they know is really at the highest point when they know nothing. And then once they start learning stuff, they usually enter the valley of despair, which I'm hoping some of you are in that valley of despair where you have to question some of the beliefs you've had. And then eventually, as you become an expert, you get the slope of enlightenment, but it takes a long time to be very confident in the things that you say when you're an expert. So many decisions on SARS-CoV-2 have been made from the peak of Mount Stupid. We also see that in storm chasing, right? You see the new person who downloads Radar Scope, and that's how they're going to chase tornadoes. And we know that there's danger in there. And that has to do with not having that wisdom and experience and knowledge. And so the Dunning-Kruger effect has really plagued us during the treatment of SARS-CoV-2. Let me give you a practical example of this. This particular patient of mine, who was 19 years old, thought that sucking on copper would decrease his risk of getting SARS-CoV-2 because SARS-CoV-2 can't grow next to copper in a cell line. And so in the midst of that, he was sucking on pennies. And you can now see that he sucked a penny all the way into the right side of his lung. You may say, is that really a penny? Well, here's the side view, here's the front view. And if I really enhance it, you can actually see that Abe Lincoln is upside down in his right mainstem bronchus. This really happened. And this is the kind of insanity that happens when people try to rely on doing their own research. Believe me when I tell you, 190%. There are millions of scientists and physicians whose sole job it is right now to help you get the right information. Doing your own research is a setup for hazards. Let me tell you why. Well, this is me panicking. This was back when we were thinking this is how we were going to treat any pandemic. It's laughable now because we don't have that kind of equipment available in the volumes that we needed. In the outpatient arena, the only thing that we know works is the Regeneron cocktail that the president got back in November. It only works in outpatients who are not on oxygen, who are at high risk for complications from COVID. It does prevent hospitalizations. It's underutilized because you have to go to a clinic to get a 3-hour infusion. And you can imagine how fun that is to set up a clinic with a bunch of patients who are all COVID positive and delivering that medication. In the inpatient arena, the only drugs that have worked are dexamethasone. I don't believe remdesivir has enough science behind it, but it's considered better than nothing, although a lot of institutions are moving away from it. And possibly convalescent plasma, where we take somebody who has successfully fought off COVID, we drain their plasma, and then we put that plasma in somebody else to try and fight the infection, and it may have a role. But guys, this is it. Vitamins, maybe D. What we know is patients with vitamin D deficiency do worse, but we have no evidence that the opposite is true. No evidence that supplementing vitamin D decreases the risk of illness. There's no evidence to support zinc, vitamin C. There is no evidence for so many things. And that's after doing scientifically rigorous work. Believe me, I would never tell you something didn't work if I thought it did. And I'll never tell you something works if I know it doesn't. And that is the truth. So the long walk of shame is famous this year. Hydroxychloroquine, we now have seen this big spike in ivermectin. We know that there was this incident with bleach earlier in the year. Some people have tried to radiate themselves to prevent the virus using saunas, hypochloric acid, colloidal silver, vitamin supplements. None of them work. And I'm going to show you how dangerous this can be in just a second. But let me be compassionate and say, I understand why people want this. Anecdotal experience. So one of the dangers, there's a book called How Doctors Think. And it talks about this thing called heuristics, which is mental shortcuts. The way that if you see somebody with an antenna on their car, will immediately assume if it's around a storm that they may be a storm chaser. That's a mental shortcut. It doesn't necessarily mean that's who they are or what they represent, but you're going to believe that. Many people use their personal experiences to guide their interpretation of science, but that's not how science works. Science is based on repeatedly testing a theory and a hypothesis. And anecdotal experience, though, is very, very strong. Many people who got sick with SARS would take some weird treatment and they'd get better. But the news is most people who have SARS and do nothing get better. There's not necessarily an association any more than there is from my first slide, which showed the number of years with a tornado nadir were correlated with outbreaks of disease severity. There's no correlation, but it feels like it because it looks good. And we're all feeling helpless like now that we don't have a treatment that's going to provide cure. And this has led to a conspiracy-driven nation. Let me give you an example with ivermectin. This is a website for a particular physician who Dr. Pierre Corey, who has come up in the news. This is his website. And here it looks like a really professionally done website. He has doctor after his name. He talks about ivermectin. He talks about the scientific evidence. But if you dig through his website, you will find that this was his answer about randomized control trials, which are the only way to prove that a drug works. He says to this question, should we do a large prospective double-blind placebo-controlled study to prove if it works before adopting yet another treatment that will not work? And he says there are several reasons why such a study would be unethical to conduct at this time. Let me stop you right there. This is the only standard we have to know if a drug works or not. Hydroxychloroquine, which looked so good in anecdotal studies that looked at associations, when fully tested against the backdrop of a very rigorous control trial, failed miserably every single time. We absolutely need this gold standard. And just because we're in the middle of a pandemic doesn't mean we should rush treatment. We really don't want to harm people, and hydroxychloroquine does cause harm. Ivermectin causes harm. Overdosing on vitamins, particularly fat-soluble vitamins like vitamin D, can be toxic. Believe me, we're trying to figure this out as fast as we can. We've made a lot of leaps in 1 year, but we can't go to this other stuff, okay? We need to be scientifically rigorous. So how do we get back to chasing? How do we get to be so cool and so chasing again? Vaccination. So I'm not going to spend long on this because I'm going to wrap in a moment. First of all, the mRNA vaccines are amazing. They're truly amazing. They aren't new though. Starting with SARS-CoV-1, mRNA vaccines were investigated, and they've been investigated for MERS. They've also been tried in HIV. There's a lot of reasons why it doesn't work in HIV, because HIV has so many mutations and it mutates very, very rapidly, and that's why they haven't worked. But they've been working on mRNA vaccines for close to 2 decades. And in that time, the safety of it has been proven time and again. The fact that the 2 mRNA vaccines by Pfizer and Moderna have almost 95% efficacy exceeds almost any other vaccine out there. The flu vaccine is only about 40 to 50% protective. But the interesting thing about the flu vaccine is if you get it and you still get the flu despite the vaccine, you're far less likely to die from the flu. Now think about that. That's 40 to 50% effective. These 2 vaccines are 95% effective, and there is preliminary data suggesting that even if you do get sick after you get an mRNA vaccine, you're not going to have as severe an illness. What is not to love about that? So we need to get over some misconceptions. They don't alter your DNA, okay? mRNA is rapidly broken down by the body. It cannot affect your DNA. There's a theoretical risk if you have active, uncontrolled HIV. HIV produces an enzyme called reverse transcriptase, which can take an mRNA strand and put it in your DNA. But any cell that does that will be destroyed because the mRNA that is coded in the vaccines creates a strong immune response to destroy those cells. That's how your immune system works. So they don't alter your DNA. That's impossible. Third, they're exceptionally effective. And the cool thing is they can be tweaked easily. As you guys know, there's all these new variants popping up. And these new variants, right now, preliminary data is they may make the vaccines less effective, but we're still talking about 80 to 90% effective. That's incredible. We're one to drop it down to 50% effectiveness, like the flu vaccine. We can literally put the new substitutions in the mRNA strand and give you a booster shot. These are going to totally change the way we fight infections going forward. Fourth, they counter the variants, like I said. And let me tell you, these misconceptions are amazing. First of all, 5G, haven't noticed any improvement since I got my shot. Microchips, not possible. If you don't believe me, ask to look at the syringe before you get it. They do not contain any aborted fetal tissue. They do not have any cancer-causing ingredients. They do not have heavy metals in them, and they do not have monkey DNA. These are the things that have been circulating on the internet, and they're dangerous. The dangers of promulgating these issues are going to keep us from being able to chase. So if you love chasing and you love science, get the vaccine when it comes. And when's it going to come? Well, we need to have 70% of the population immune, and natural immunity is not enough. You need to be vaccinated. So right now we're still in phase 1, but over the next 2 to 3 months, we should eventually get to phase 3, which includes the general population. And the good news is that's all of us. If you don't get your vaccine, the danger becomes we're not going to hit 70%. If we don't hit 70%, you can expect that we will continue to have surge after surge of COVID. They'll be less severe for those who've been vaccinated, but we'll never go back to life as normal. If you want life as normal, trust science. You do it when you storm chase. You trust the radar data you're looking at, which was evidence-based. Trust science here. Don't listen to anecdotes. If you want data and you don't believe what I'm saying, I will help you find the data that shows you this. This is not some big conspiracy. All right, this is what I want to go back to again. I miss these guys, and I haven't seen them in almost 2 years. And I won't probably see them this year either. So we need to get back to chasing. That's what we need to do. So I'm going to go ahead and stop there. And I want to thank you guys for your attention on a topic I'm sure you are so burnt out on. I'm going to take just a few minutes to go through some of the Q&A questions real quick. So one question was, all the people that claim they can't wear masks because of asthma, that is not true. Actually, masks will decrease asthma by capturing pollens and other irritants that end up causing bronchospasm, so that's not true. I would love to have this data table, the one for mask wearing, to share with deniers. That's possible, absolutely. I will, I'm not sure, Eric, can we post my presentation? I can send you a copy somewhere on the website.
Yeah, we can. And the whole summit's going to be reposted for everybody to view later this afternoon. We're recording, so anybody can go back and rewatch.
Perfect. The next one is, should we be concerned about wearing safety glasses to protect ourselves? Great question. So we do know that droplets can actually infect you through your eyes, which is just like the most terrifying thing of all. Inpatient, and we know in the inpatient realm, we use the following. We use the R naught to figure out whether or not we're wearing masks. The R naught is less than 1, goggles or face shields. If the R naught is less than 1, generally we recommend against it. If it's greater than 1 in your area, yes, you should. And the type of glasses that you have to wear cannot be these. You really do need something that wraps around the face, like safety goggles. And I don't recommend it for going out to casual areas, but if you're going to be in a highly dense area, that is something that can help that. I think I've answered ivermectin. So the NIH came out with a statement that they don't have enough evidence to make a recommendation one way or the other. And the sad reality is, when that recommendation is the recommendation on rigorous control trials, it almost never bears out that it is effective. Then there's a question about bamlanivimab. We are early in the bamlanivimab, which is really hard to say. It's a monoclonal antibody treatment, which targets the ACE2 receptor, which is one of the receptors that we know is what SARS uses to go into cells. And so we'll know more. I'm hopeful. I really am. One question about can SARS be spread through tornadoes? And the short answer to that is that actually was a discussion point we had a year ago about whether or not weather systems could spread that. As we know, tornadoes can cause asthma by kicking all of the stuff into the atmosphere that's normally on the ground. And we know from the Joplin tornado and other powerful tornadoes, you can get infectious agents that are normally trapped in the soil airborne. The good news is the dispersing winds would make it very unlikely for COVID to be spread that way, and that's good. Another person brought up, and I'm almost done, I swear, I'm watching the clock. I know Reed Timmer just wants to just shove me off and talk about the Rockets, but here it is. Don't worry, Reed, I got your back.
No, we're good. You're good.
Okay, I promise. I'm almost done. Almost.
You can take all day if you want.
No one wants to hear me talk all day. Least of all me. We have not seen flu this season. Guess what? The flu for this year is highly infectious, and we have not seen it. You want to guess why? Social distancing, kids at home, mask wearing. Just imagine what it would be like if we didn't have to deal with seasonal viruses. I can tell you that when COVID's over, every single respiratory viral season, I'm going to be wearing a mask. I have not been sick in over a year. It is the single best thing I've ever experienced. And then there's a couple questions about masks. Anything works, but if you're going to buy a mask, a double layered mask is great. If you get the pseudo surgical masks, those are fine. There's no benefit of cloth versus paper. Taking bathroom breaks and chasing. So again, fecal transmission of COVID is a real thing. because people don't wash their hands. So if you wash your hands 20 seconds after you use a public restroom, you're good. But most importantly, wear your mask, because the most dangerous part of the toilet, this is so great. I never knew I'd become an expert on this. I swear I don't. When you flush the toilet, that's the time that it becomes aerosolized. So when you flush the toilet, anything that's around the toilet gets aerosolized. So you don't want to flush the toilet and not be wearing a mask. That's really there. And I think, what's the best way to deal with areas for where people don't wear masks? The short answer is the single best thing that you can do is take care of yourself. Wear a mask and socially distance. You're not responsible for other people, and that's really important. I don't agree that it's a personal decision. I think if we want a way out, we've got to do what we've got to do. I will type answers to other questions, but otherwise, I want to thank you all for your attention, and I'm really excited to hear about things being set on fire and launched into tornadoes. So I'm going to turn it over to Reed. Thank you, everybody.
Okay, everybody. Do we have